Hey folks, Professor Finn here. Today we're going to be looking at Chapter 19 in Embalming, History, Theory, and Practice, 6th edition by Sharon Gee-Mascarello. As always, don't forget to like, share, subscribe. Make sure you pass this around to some of your mortuary science student friends, practitioners, or others interested in funeral service stuff. Don't forget to drop a comment in the comment section below, maybe about what I could do to improve the videos, or where you're even from, so we can see where these videos get distributed to. Right now, let's get the screen shared and talk about delayed embalming. Post-mortem changes begin at the moment of death. Lengthy intervals between death and embalming can exacerbate these post-mortem changes. Optimal embalming outcomes with the fewest complications are achieved when embalming is performed within a short time interval following death. A spectrum of factors can speed or slow post-mortem changes. Embalming considerations in this chapter include those commonly encountered where there is a delay between death and preparation. Numerous factors are considered during the pre-embalming analysis. Note all post-mortem conditions on the embalming and decedent care report. Post-mortem chemical and physical changes do not occur simultaneously throughout the body. Time delays between death and preparation present three common embalming challenges: non-uniform distribution of embalming solution, swelling, and increased preservative demand. The embalmer can anticipate challenges in achieving uniform distribution of the injected arterial solution. This is caused by a variety of reasons and can result in some areas receiving too much solution and other body areas receiving little to no solution at all. Tissue swelling can occur anywhere, especially in the face and neck. Bodies dead for long periods of time do not assimilate the arterial solution well. The longer decomposition processes can continue, the greater the preservation need. Decomposition will continue until the process is chemically arrested. Even in cooler temperatures, decomposition slows but does not stop. Preservative absorption by tissue proteins is usually greatest immediately after injection. Most bodies exhibit some degree of firming during the injection process. If a sufficient amount of preservative has been injected, complete firming of the body will occur several hours to a day later, and there are a number of factors that influence the degree of fixation. As these bodies are subject to swelling, use of a minimum amount of a stronger arterial solution best establishes good preservation and minimizes tissue distension. Hypertonic or stronger arterial solutions help to minimize swelling of the tissues. So first up, let's talk about some manual aids. Manual aids can be lowering hands below the table, squeezing the sides of the fingers in the nail beds, bending, rotating, and flexing of the limbs, massaging the dependent areas to distribute solution, elevation of the affected area, chemical compresses, water compresses, and pneumatic collars. The following are examples of mechanical aids: drainage instruments, injection pressure, pulsation, rate of flow, diameter of arterial tubes. Last, we have operative aids: channeling, wicking, incising, and excising tissue. Now, it is important to note that when you are looking at any one of these aids, this is the list of what those are. So lowering hands would be an example of a manual aid, and if you were to be asked a question about manual aids, this is the list of items that you would be asked about. So general embalming treatments. Throughout the process of arterial injection, the embalmer asks the following questions to evaluate the degree of preservation. What body areas are receiving arterial solution and which are not? What can be done to stimulate arterial solution into body areas where the arterial solution is not being distributed? And is there sufficient arterial solution volume in all body areas? For under-embalmed areas, the embalmer has three choices: arterial injection, hypodermic embalming, or surface embalming. Restricted cervical or 6-point injection are the optimal choices for delayed embalming, 1 point is not recommended. Restricted cervical injection. Inject the trunk and limb areas first. Be certain the arterial tubes directed towards the head remain open during injection. Arterial solution that has reached the face and head by collateral routes will exit from the open tubes. Inject the head last, left side and then right side, the same as we've read in other chapters. If purge develops, the restricted cervical method allows the features to be set and the body aspirated before the head is injected. Now, why is that important? Well, if we inject the body and we're worried about swelling in the head, what we can do is we can aspirate the body, take pressure out of the system so that when we inject going into the head, then we won't have any buildup of pressures, thus causing swelling. A 6-point injection. Raise all limbs and neck arteries. In order from left to right, inject the legs, the arms, the trunk, and then the head. Drainage can be taken from each accompanying vein as well as the right internal jugular. If the body has been autopsied, the 6-point or multi-site injection is standard. Well, if the body's been autopsied, you're going to be working under autopsy standards. So arterial strength and volume. A moderate to strong, well-coordinated arterial solution is needed when decomposition is evident and when the body is in the active stage of rigor. 30 index and above arterial fluids are recommended. Special purpose fluids are also recommended for difficult cases. Co-injection fluids work synergistically with the arterial fluid to produce optimal results. The first half-gallon injected can be less strong to clear blood discolorations, and hypertonic solutions, 2% strength and higher, can follow. Waterless solutions may be used effectively. Additional dye indicates distribution or lack thereof of arterial solution and helps to prevent graying of the embalmed tissues. Instant tissue fixation is recommended for extreme cases to minimize tissue swelling and provide maximum preservation. The total amount injected all depend on your embalming analysis and continued observation during injection. When there has been a lengthy delay between death and embalming, inject solution slowly. Slower injection helps to prevent coagula in the arterial system from moving into and blocking the smaller distal arteries. Rapid injection can cause intestinal distension, which creates internal pressure upon the contents of the stomach and results in purge. During sectional injection of the arms and legs in the autopsy body, higher pressures and faster rates of flow may be needed to establish distribution. Always start slow and then build up speed if you see nothing happening. Or always start at a lower pressure and build up as you go in. The pulsation setting on the embalming machine is effective in distributing fluid to the extremities. Higher pressures can be used with pulsation. A pulse flow can be created manually by turning the rate of flow valve on and off, turning the stopcock valve on and off, and by bending and unbending the delivery hose to start and stop the delivery of the fluid. So embalming bodies in rigor. Embalming a body in the intense state of rigor mortis is challenging. This is especially true when the decedent is well muscled. Fully established rigor is difficult to relieve when large amounts of muscle protein are affected. Rigor is more easily relieved in bodies with underdeveloped musculature and those with low protein content. Cachexia is an example of a wasting disease that reduces muscle protein. Rigor mortis is discussed at length in Chapter 5 of this textbook. Well, jump back into Chapter 5 if you need a refresher. Rigor mortis is recognized within the first 2 to 4 hours after death. Within 6 to 12 hours, it is fully established. And rigor passes in approximately 36 hours following death. The sooner it starts, the sooner it ends. The passage of rigor is indicative of the start of the decomposition cycle. Rigor comprises 3 general stages: primary flaccidity, active rigor, and secondary flaccidity. Preservative demand during primary flaccidity is related to the post-mortem conditions observed during the embalming analysis. Rigor is not a factor. If you are in primary flaccidity, rigor simply hasn't happened, and it is not something you need to take into consideration. Bodies embalmed during and after rigor mortis have a higher preservative demand. A body in an active state of rigor absorbs very little preservative. Higher strengths and volumes of solution are necessary to compensate for the poor absorption. Saturate the tissues with a well-coordinated solution of sufficient strength to meet the preservative demands of the body when rigor has passed. Otherwise, the tissues will soften as decomposition progresses. Positioning challenges are expected. Features may be difficult to set, and packing of the throat may be impossible. Distribution of fluid may be poor due to extravascular pressure and narrowing of the lumen of the arteries. Drainage may be poor due to extravascular pressure upon the small veins. Tissues easily swell, and the pH of tissues is not ideal for fluid reactions. Tissues may not firm well after the passage of rigor due to poor absorption and lack of sufficient volume of arterial solution. Tissue firmness caused by rigor can be a false sign of tissue fixation by the preservative. Remember that ideal pH for preservation is about the same as normal healthy tissue, 7.38 to 7.4 on the Sorensen scale. Also, pH values will not be the same in the muscles. During rigor, there are few sites for the reaction of preservative and proteins. After rigor, there are many sites for reaction of preservatives, in addition to selecting strong embalming fluids. A high-strength solution includes the addition of co-injection fluids. The supplemental co-injection fluid adjusts tissue pH, buffers the arterial fluids, and promotes uniform distribution and diffusion of the preservative. The strength of the solution is not altered by the addition of co-injection. Tissue firmness cannot be relied on as an exclusive measure of preservation. Firmness may only indicate muscle stiffening caused by the rigor. So, setting features during rigor. Massage of the soft tissues at the temporomandibular joint and the temporalis muscles can be effective in relieving rigor that is firmly set in the jaw. Press the jaw firmly upward with the palm of the hand to exercise the joint. A slight parting of the teeth will allow placement of packing material into the throat using long forceps. When the mouth can be fully opened for sanitation and packing, use a suture closure or needle injector to align and secure the jaw. Body positioning during rigor. Firmly rotate, bend, flex, and massage the joints and muscles of the neck, arms, and legs. Rigor in the neck is relieved by moving the head back and forth and rotating side to side. Grasp all fingers together and gently straighten them. To relieve rigor in the legs, exercise the hip joint and bend and flex the knee. Prior to the routine use of body bags, tissue dehydration was a common condition. Rotate feet side to side. Now on to the arterial injection. As stated previously, restricted cervical or a 6-point injection may be needed to thoroughly embalm bodies during rigor mortis. A 1-point is not ideal. The right internal jugular vein is the most suitable drainage site. If using 6-point injection, you can drain from each site in addition to the right internal jugular vein. Clear blood discolorations by first injecting a milder solution, then meet preservative demands by increasing the solution strength above 2%. Dye and co-injection fluid can be added to the solution. The dye merely indicates that surface tissues have received fluid. Dye cannot indicate effect on the deeper tissues. Inject slowly, and during injection, continue massage and manipulation of the limbs to encourage distribution. If a 6-point injection is used, higher pressure and rates of flow can be used for direct injection of the limbs. Pulsation will assist. Short-term mortuary refrigeration is necessary to suspend naturally occurring post-mortem changes, and most bodies transferred from medical or forensic institutions have undergone refrigeration for some length of time. Numerous decomposition changes are often evident in bodies refrigerated for lengthy intervals. The embalmer can overcome many challenges presented by decomposition. Thorough embalming, coupled with feature restoration and cosmetic application, can produce acceptable results. Prior to the routine use of body bags, tissue dehydration was a common condition when bodies were wrapped in cotton sheets and refrigerated. Lips, eyes, and fingertips were noticeably affected by moisture loss. Plastic body pouches prevent excessive dehydration, but do not completely stop moisture from leaving the tissues. The plastic enclosure traps body heat and moisture, and as the core temperature of the body cools, condensation forms within the bag. Desquamation, or skin slip, discolorations, and gas accumulation in the body cavities are accelerated by trapped heat and moisture in the pouch. Both plastic and cloth coverings present disadvantages over time. Now, your book lists a number of disadvantages to long-term mortuary refrigeration with plastic pouches. These disadvantages are similar to general disadvantages to refrigeration, which has been mentioned in other places in this textbook. So this is not a new list, it is simply a restatement of a list that we've already seen before, except now specifically under the topic of refrigerated and delayed embalmed bodies. If the body has been refrigerated for a long period and wrapped in cloth sheeting, dehydration will be an issue. The most common places that dehydrate due to hypostasis will also be influenced by the wicking nature of the material. Swelling is always a concern when embalming is delayed. Distension of the hollow abdominal viscera is caused by trapped heat and gas accumulation. This can cause purge. The presence of rigor mortis and the increased moisture content in the dependent tissues increase the preservative demand. Arterial injection of the trunk should always be slow, using a strong, well-coordinated arterial solution with added tracer dye. Distribution may be difficult to achieve and drainage may be limited. The amount of fluid and volume of solution is determined during pre-embalming analysis and adjusted during arterial injection based upon the observable results. Eyes that appear sunken can have tissue builder injected hypodermically behind or within them to improve the appearance. Make sure that needle entry sites are sealed or the eye will leak. Super adhesive glue can be applied if necessary. Now remember, tissue builder will close the hole made by the needle. Anything else will not. Restricted cervical injection is recommended for separate injection of the face from the trunk. Notice a trend here. The trunk and limbs can receive a different solution than what was used in the head. Do not be afraid to use different fluids and different strengths in different areas of a body. Drainage may be difficult to establish because of increased blood viscosity and coagula, so the right internal jugular vein would be the best choice for the primary drainage site. Dependent areas of the trunk, buttocks, and shoulders that do not receive sufficient fluid are treated by thorough hypodermic injection. Cavity fluid can be injected using either a small gauge or infant-sized trocar. Once restricted cervical injection or multipoint is used, the cavities can be aspirated before the features are set, and the head and the facial tissues are embalmed. If purge develops during embalming of the trunk areas, aspirating before setting of the features eliminates the need to reopen the mouth and remove the purge. Cavity embalming should be thorough with a total of 32 to 48 ounces of concentrated cavity fluid being used, and reaspiration is always advised on these types of bodies. If gases escape when the trocar button is removed for reaspiration, the abdomen appears distended with a large surface vein on the neck appearing distended, the cavity should be re-injected with concentrated cavity fluid after reaspiration. So final treatments. The hair and body should be washed at the completion of the preparation and thoroughly dried. Allow the body to reach room temperature prior to cosmetic application, as condensation on cold tissue impacts the adherence of cosmetics. Apply a light coating of massage cream to prevent surface dehydration. Hypodermic injection of tissue builder enhances the contour of sunken and dry features. Sub-temperature refrigeration units used for extremely long storage will actually freeze body tissues. Medical examiners may use this type of refrigeration to completely stop decomposition of unidentified remains. Ice crystals form in frozen tissues and will damage capillaries as the body is handled during transfer and embalming. This will cause swelling. Manipulate the body as little as possible and allow the body to warm gradually to room temperature. Avoid the use of warm water to thaw out the tissues. Desquamation will be accelerated. In another twist on this, if you are using warm water to thaw out tissues on the surface of the body, those tissues will thaw and start to decompose while the tissues underneath are still frozen. So when you try to inject them, you will get nowhere with it. So it is important that when you are working with frozen tissue, you need to give it as much time as possible to come up to room temperature in order to do the most thorough job. Expect minimal blood drainage from frozen bodies. Inject arterial solution slowly to prevent capillary rupture and exacerbate swelling. Waterless solution should be considered. Additional dye for tracing and sectional embalming is anticipated, along with hypodermic and surface treatments as necessary. Some of the factors that speed the onset of decomposition include elevated environmental heat, elevated and retained body heat, high moisture content within the body, and translocation of intestinal bacteria. One of the first external signs of decomposition is a green discoloration in the lower right quadrant of the abdomen. As decomposition advances, the outline of the large intestine can be observed. Hydrogen sulfide produced in the colon after death reacts with the end products of hemoglobin breakdown to produce the green discoloration. Vascular changes. Early decomposition color changes visibly affect the small veins. Marbling or spiderwebbing will be apparent. Livor mortis and stain. Livor mortis is completely established in the dependent tissues. Livor mortis is intravascular and will favorably clear during injection, while postmortem stain will not, since it is extravascular. Stain can be lessened by bleaching. Bleaching agents are arterially and hypodermically injected or applied as a surface compress. Petechia and purpura are extravascular and are not cleared by arterial injection. This includes Tardieu spots. Petechia, purpura, ecchymoses, Tardieu spots, these are all bruises. All bruises are extravascular. Exposure to air currents draws moisture from the tissues. Dehydrated tissues will shrink and become wrinkled. Extreme dehydration causes the tissues to harden in a condition known as desiccation. Odors. Cadaverine and putrescine are commonly associated with the odor of human decomposition. During life, putrescine is associated with the smell of bad breath. 8 gases are identified as the primary contributors to the smell of death. Indole, which smells like mothballs, scatole, which smells like feces, putrescine and cadaverine, which smell like rotting fish. Dimethyl disulfide and dimethyl trisulfide, which smells like foul garlic, hydrogen sulfide, which smells like rotten eggs, and methanetriol, which smells like rotten cabbage. Foul amines and mercaptans combine with ammonia and hydrogen sulfide to produce the odors of decomposition. Embalming converts the amines, mercaptans, and hydrogen sulfide to odorless compounds. Formaldehyde converts ammonia to odorless hexamethylene. Strong odors can be reduced by bathing the surface of the body with a solution prepared by mixing 2 pints hydrogen peroxide with half cup of baking soda and adding a tablespoon of liquid soap. This solution is left on the skin surface for several minutes before rinsing and drying. If gases have developed in the abdominal cavity and products of partial digestion were present in the stomach at the time of death, purge can be expected. Ruptured capillaries and congested lung pathways may also create lung purge. Abdominal pressures may also cause purging from the rectum through the anal orifice. In some bodies, especially those in which bacterial activity increased after death, the tissues and cavities may contain gases. Conditions favoring gas formation are heat and humidity, and those hindering formation of gases are cold and dry environments. Gas can cause bloating and swelling of the body, protrusion of the tongue and eyes, and distension of the male genitalia. Distension of the abdominal cavity can create lung, stomach, and anal purges. Skin slip. The autolytic changes that begin immediately after death weakens the superficial layer of the skin. Gases can easily move the weakened superficial tissues, resulting in blisters and separation or slipping of the skin layers. Chemical changes. Although not visible, important postmortem chemical changes occur in the tissues. Autolytic and proteolytic decomposition of the body proteins results in numerous nitrogenous products. These products neutralize formaldehyde and greatly increase the preservative demand of the body. Embalming protocol. The protocols for embalming the bodies discussed in this chapter are similar because all the bodies have undergone a delay between death and preparation and all have a high preservative demand. Generally speaking, there is a protocol for bodies that are uncomplicated. And then there is a protocol for complicated cases. And what is a complicated case? Anything other than normal, which is basically everything that has been described in this chapter, delayed bodies, autopsies, etc. So all these protocols are generally similar. Think about it. When we run into potential difficulties, it recommends, the author and the chapter editors recommend multi-point injection or restricted cervical, stronger arterial fluids, etc., etc., etc. Select maximum index fluids, 36 or higher, to mix a hypertonic solution. The goal is to deliver a minimum volume with maximum preservation, and the goal of this is to reduce swelling, or the chance of swelling. Avoid pre-injection fluid. If you are going to flush the body of blood discolorations, you should be using a milder fluid, a milder preservative fluid to do that, and then increase the index to meet preservative demand, and use additional dye to trace distribution. Use restricted cervical or 6-point injection, and always inject the head last. Collateral circulation delivers preservative to all areas of the body regardless of the direction of injection. The face receives solution while other regions are directly injected. If the abdomen is distended tightly with gas prior to arterial injection, introduce a trocar into the abdominal cavity to relieve this pressure. The trocar should be kept just beneath the anterior wall. The trunk should be injected at a very slow rate of flow to prevent swelling of the abdominal viscera and purge. Limbs can be injected slowly at first and then at higher pressures and faster rates of flow to secure distribution. If desired, each extremity can also be injected by the instant tissue fixation and waterless embalming methods. If sectional arterial embalming has produced unsatisfactory results, sectional hypodermic injection will be necessary. Undiluted arterial fluid may be injected by machine through a hypovalve or infant trocar. Please note, all the primary and alternative trocar injection sites, many of them are common sense and also mentioned in restorative art. Now, what this means is when you are using trocar or hypovalve trocars or infant trocars, there are hidden points of entry. And use those hidden points of entry so that you can easily conceal your work, especially in visible areas. Superglue can be used to close trocar holes or hypodermic entries. Remain should be reaspirated several hours after embalming, and reinjection is strongly advised, especially if any gases are evident during the reaspiration. Any loose skin should be removed and surface compresses applied to help dry skin slip areas. Air drying also helps to dry the raw skin after the compresses have been removed. Plastic garments with embalming powder should be used. Preservative powder produces some surface preservation and helps to control odors. In preparing a body in which decomposition is evident, the embalmer may wish to vary the technique used to set features. When restricted cervical injection is selected, the mouth can be closed after arterial injection. As the lips and areas around the mouth swell, it may be easier to obtain a proper closure after injection. The embalmer should evaluate the preservation of tissue surrounding the mouth, and it may be necessary to place cotton in the mouth and saturate it with concentrated cavity fluid to help preservation. A very important fact is listed next. Dehydration is generally never a concern in a decomposing body. I'll say it again. Dehydration is generally never a concern in a decomposing body. Why is that? Well, simple. As your body is decomposing, it is releasing more and more and more water from the cells. So generally speaking, if your body is actively undergoing decomposition, it is quite literally leaking fluids. So we don't have to worry about drying the body out. We can use the strongest fluids we can at very high concentrations or waterless and have no ill effects from that type of solution. Eyes can be closed until after arterial injection when restricted cervical injection is used. If the lids appear under-embalmed, cotton can be used for closure along with cavity fluid to ensure preservation. Eyelids should be handled very gently to avoid skin slip. Areas of the face that have not received sufficient arterial solution can be reached by hypodermic injection from inside the mouth. Cavity fluid should be used to treat these areas. Make all injections from inside the mouth because cavity fluid has a tendency to leak from the tissues, so any leakage will occur in the mouth. A 17 to 22 gauge needle is ideal for hypodermic treatments. Remember the rule. If you are bleaching something or trying to dry it, you use phenol, carbolic acid. If you are trying to preserve it, you use cavity fluid. In bodies dead for a long period, the submaxillary, sublingual, and parotid glands tend to swell during injection. If this happens, Apply very firm digital pressure to these areas immediately after arterial injection. If swelling is not reduced, make a semilunar flap incision at the base of the neck. Use the hypodermic or infant-sized trocar as an operative aid to lance the glandular tissue several times and apply digital pressure. If still unsuccessful, excision of the swollen tissues may be necessary. The tongue often protrudes and appears grossly swollen on decomposing bodies. The protruding tongue can be covered with folded cloth or cotton and firm pressure applied to push the tongue back into the mouth. Perform this treatment prior to arterial injection. Excision of the protruding tongue is the last option for consideration. Permission should be secured from the authorizing agent prior to this procedure, as this could be considered mutilation, which exceeds that which is normally permitted under an embalming authorization. Advanced decomposition protocols. Severe conditions may prevent acceptable restoration for viewing. The primary purpose of postmortem treatment for severely decomposed bodies is to control odor and slow the progress of decomposition until final disposition. Some level of preparation of the body should be attempted. Best practices include donning a respirator when medically approved and operating the ventilation system for the maximum of room air changes. The protocol for these types of cases, these severely decomposed cases. Confirm identity. Photograph all original identification bracelets or tags. Leave physical tags with the body. Prepare 2 external identification tags to affix once the bag is closed. Remove, document, and secure any personal effects prior to final treatments. Proceed with treatments after donning the appropriate personal protective equipment. After arterial injection can be effective for preservation purposes only. The arteries are one of the last structures in the body to decompose. Some level of distribution is expected. Severe swelling should be anticipated during injection. Special purpose fluids are available for arterial injection, and drainage should not be expected. Aspiration of the cavity may not be necessary, and cavity injection can be effective for just preservation purposes. Now, even though it says aspiration may not be necessary, aspiration is still someplace you should probably start just to help things out a bit and remove fluids and other material that is accelerating the decomposition process. Inject a large volume of cavity fluid to ensure internal drying of the viscera and to control odors and leakage. The extremities and trunk walls can be treated by hypodermic injection. Treat body surfaces with a liberal application of autopsy gel followed by preservative and drying powders. Wrap the body in a blanket or several sheets before transferring to a heavy-duty body bag. Saturate the blanket or sheets with cavity fluid or a phenol solution. Apply glue along the zipper and cover with strips of cotton to prevent escape of odor and leakage. A second body pouch may be necessary. Affix another identification tag when a second pouch is used. Folks, this concludes the lecture. Once again, feel free to like, share, and subscribe. Share this with a friend. Drop something in the comments below to tell me how I'm doing. We will see you next video.